Ladies and gentlemen, this is not loud enough. Everybody, thank you so much. Thank you for coming. Thank you for taking some time. Thank you, hopefully, for leaving at least 3 either sliders or taquitos for us, because we didn't get any sliders or taquitos yet. I'm just speaking for everyone. Thank you so much for taking a little time to do some learning. This is, I think, going to be educational, possibly a little bit fun. I don't know. It's unpredictable. Let's see how it goes. But it's a great opportunity for us to get to talk about something that is super exciting for all of us, because this is not hyperbole. This is a revolutionary time for our patients, because we are turning from old medicines to new medicines in a very gratifying way to make the quality of our patients' lives better, and hopefully the amount of their lives better as well. So we're going to do some learning today. The first and most important thing is that this is going to be AIAP, as interactive as possible. Just made up that acronym right now.
So good.
Yeah. As interactive as possible. And here's how we do it. You have a phone. I'm just guessing. I don't even know you. But I'm guessing that you have a phone. And you're going to, if possible, open up, I think, the camera app. And you're going to take a picture of...
Next slide.
On those little papers. On the next slide, we have it here. Oh, that's a good one. Either take a picture of that, or on the little brochures right next to you, on the front bottom left, there's a little barcode, and you're going to take a picture of that. And magically, a bunch of stuff that none of us really understand is going to happen with satellites, and then we're going to be connected in some way. Hopefully not in any way that's weird or painful for us, but I think it's just for questions mostly, and comments, and you can also download slides from there. If anyone has trouble getting it working, there is a 12-year-old walking around, and you can just try to I was about to say you could grab them, but that sounds weird now that I'm hearing it. Yeah.
Weird, yeah.
Okay. You can raise your hand, and a 12-year-old will come by. And if you can't find one, I'm going to call my nephew, we'll get him on the line, and we can set the whole thing up. It should be real simple. And the nice part about it is, as we are going, you can, I'm actually going to say should, sort of virtually interrupt us, ask questions. There are also going to be a few question slides. We're going to ask you questions, and you should answer them. And again, you can download the slides. So if any of us from New York and we speak really quickly, that's okay, because you can download the slides afterwards and it'll be fine. We're going to try to make it as interactive as possible. If there are questions, also there are some staff walking around and you can grab them and they will help you. Good. You've had your chance. You've got the paper in front of you one way or the other. We're going to make this be interactive. We're going to be talking today about getting what we think are some of the best therapies available to our patients, specifically our patients with relapsed and refractory diffuse large B-cell lymphoma, and employing bispecific antibodies, again, to make their length and quality of lives hopefully better. Okay, my name is Josh Brody. I work at Mount Sinai School of Medicine in New York. If any of you have not heard of New York, it's right next to Jersey. It's the next one, right over there. It's beautiful. Please come visit. We recently got a Starbucks, so really excited about that, so come check it out. And I do also have to apologize to Lorna, because she's heard that joke 3 times now.
Still laughing, though.
So, yeah, but I have to retire it after this. 3 is all you get. Yeah. So thanks for being cool about it. To my right here is Dr. Liz Brem, who's Associate Clinical Professor and Vice Chief of Clinical Affairs at UCI in beautiful Irvine, California. And Liz and I have known each other for a bit, but I was just finding out recently that you have an accent over here. I never realized it before. So is it Brem or is it Brem?
Oh, my husband's going to be so happy that you asked this question. So it's Brame as in rhymes with name.
Oh, it was not even close the first 2 times. Okay. Good to know. Okay, and then Lorna Warwick does not yet have any accents over her name. But we are open, I think, to things. And
we could try.
It could become Warwick. We haven't finalized anything for sure. And Lorna Warwick is the CEO of the Lymphoma Coalition, coming out of Ontario, Canada. Liz, Lorna, welcome. Thank you. We're going to keep going, and you're going to get to hear a little bit more from both Liz and Lorna if I eventually stop speaking. We're going to try to make this be palatable, because it's all going to be organized around actual cases. So there won't actually be the actual names of the patients. The patients are actually based on, actually not either, I don't think either of our patients. One of them I know is based on a patient of a colleague of mine. So they are real patients, and we're going to try to do some learning in the context of how we actually approach therapy of some of these patients. And we're going to start with this question. If you haven't done the barcode phone thing yet, at this point it's on you. I mean, I really made a big thing about it on the first slide. So here's the first question. How familiar are you with bispecific antibodies? And specifically, we're asking about in the context of lymphoma. So we're going to ask about lymphoma. You have little or no experience, lymphoma moderate experience. In other cancers, myeloma, small cell lung cancer, little to no experience. Other cancers, moderate experience. Or you use these things all the time in lymphoma. I was really hoping it was going to be Fleetwood Mac. I honestly thought it was going to be for some reason. I don't know why.
Maybe we can put in requests next time.
I think it'd be nice if we, I don't know if you guys have any Pat Benatar, something? Yeah, okay. Oh, okay, sorry. Okay, so it's a nice group because it's a little bit heterogeneous, but you know, tough to go from 0 to 60 miles an hour, but easier to go from 10 to 60 miles an hour. So everyone here is starting with some a priori knowledge, which I think will make the whole thing even more palatable. And it's great because what we want to get people to is just be as comfortable as possible with this new class of therapies, because I think we have some consensus that they are great for our patients' lives. So good, we're starting from somewhere, a little bit of heterogeneity. So I'm going to start by asking Lorna to share some of the most important things we're going to talk about today, which is how these things actually impact our patients' quality of lives.
Yeah, so thanks, Josh. Just really briefly, I'll be talking throughout this presentation using some data that we've collected through a global patient survey that we do every 2 years. This data will come from the 2024 version of the survey. It's an online survey conducted internationally. It was available in 20 languages, and overall we had just over 11,000 patients. So it's a really rich data set. Lots of learning about patient experience in all kinds of ways, and I am really excited to be able to share that with you.
It's super exciting because this is an incredible resource because we do not have a lot of data sets of 11,000 people giving their take. So it's an awesome resource, and we're lucky to be able to share some parts of it today. Thanks, Lorna. Okay, folks in the audience probably are familiar with the fact that we have a few FDA-approved bispecific antibodies, and there's a little bit of nuance here. So the first two things you see here, epcoritamab and glofitamab, are specifically FDA-approved for DLBCL. Mosunetuzumab is FDA-approved for follicular lymphoma. Some folks are aware of this. Not FDA-approved for DLBCL, but it is being studied in DLBCL, sometimes as monotherapy, sometimes in combinations. And even though it is not yet FDA-approved, already does have an NCCN recommendation in combination with polatuzumab, and we'll talk about some of that data in about 21 slides from now. So again, this is a new-ish era, but we have been using these medicines for, probably well before their FDA approval, 4 or 5 years. So I think we have a lot of comfort. Some of the folks in the audience have probably been part of clinical trials as well. But even since FDA approval, already now a couple of years of access to these medicines for our patients. And therefore, folks in the audience probably already have some questions. So again, you're going to, as we're going, you won't really interrupt us because it's moderated. But as you have questions as we go, please just chime in. Liz, how do you do this? Not about how pronouncing her name, but with medicine stuff. And we will do our best to try to answer as we go. Okay, I won't comment more about the FDA labels. We're going to get right to it with an actual patient. And again, that's what I was chiding you to do. Okay, this is a patient who is now going to be in third-line therapy. So Henry is 82. He has relapsed and refractory diffuse large B-cell lymphoma after a couple of lines of prior therapies and comes to meet you in your clinic to discuss the plan going forward. So Henry lives by himself. He has a daughter and niece that live nearby. Don't really know, but I think he has a good relationship with both of them. We got to double check on that. I believe he does, 80% sure. And for frontline therapy, he received Pola-R mini chip, an elegant approach, and he relapsed. He had a complete remission, and he relapsed about 12 months into it. As a second-line therapy, he received tafasitamab and lenalidomide. And got continuous therapy that had completed 8 months ago, and now he's showing up with recurring weight loss and night sweats. He has a history of peripheral neuropathy and osteoporosis and high blood pressure. So right off the bat, we're going to put it to you guys. Henry, you remember the basics, 82, third-line therapy, Pola-R mini chip, Tafalen. How would you treat Henry now? 1, CAR T cells. 2, epcoritamab. 3, chemotherapy. 4, glofitamab. Now, guys, there is not really right and wrong answers here per se, if that takes some pressure off of you. But still, there's some pressure, because if people are looking over your shoulder and you put a dumb answer, we're going to make fun of you. So there's some pressure here. It's not a complete free-for-all. I think the DJ actually wrote this song. That's why, yeah.
Sense, yeah.
Okay. Well, that's super interesting. I was not sure how this was going to go. We got a majority voting for epcoritamab and significant minorities voting for CAR T and glofitamab. I don't know how the p-value is of this, but CAR T actually beat glofitamab. That's kind of impressive. Impressive, I'm thinking just because Henry is 82 years old. And we have treated 82-year-olds with CAR T, but it's just not always you think of your first go-to thing. Let me, instead of putting all you on the spot, put Dr. Braham on the spot. Liz, any feeling? How would you treat Henry?
As somebody who has led trials for older patients with large cell lymphoma, I do think that not all 82-year-olds are the same, and I do think that at least the correct patient and the right cell therapy product could potentially be delivered here if that is something he's interested in.
You're being a little diplomatic, but I feel like you're pushing towards CAR T, I think. You're saying if he's a young and 82 and healthy 82.
I think an 82 who's living independently, has support nearby, and is understanding of the process, I don't think it's off the table, and this would become very much shared decision-making for me between CAR T cell. The major difference here between these two bispecific antibody options are the fixed duration versus continuous, and I think this would be probably one of these discussions that takes about an hour to kind of decide together what we're going to do.
I like what you're saying because you are, acknowledging some equipoise between the options. It's not a blatantly this or that. You're reminding us that not all 82-year-olds are the same. I mean, I know that for sure because my dad is almost 82, and most of you are not my dad, so I know you can't all be the same. So there clearly are different 82-year-olds. And we should keep an open mind that some 82-year-olds, that can be a great option for them. All reasonable options. Okay, and if you talk real fast, an hour-long discussion with him could go a lot faster. So hopefully he's from some place where they speak real quick. So we're going to talk a little bit about the data that is driving decisions for taking care of patients like Henry, but more than that, just also the patient's experiences as well. Okay, so overall, again, we were lucky to be in this era. Many of us were practicing lymphoma oncology long before, even before the rituximab era, and long before the CAR-T or bispecific eras, and it is super gratifying. Not to make fun of the rest of the world, but the rest of the world gets better, worse, better, worse, better, worse. But medicine and science mostly gets better, 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 better. So we are very lucky to be in that part of the world. All of us here are. And also we get like sliders and taquitos. It's very lucky. So this era is heralded by the fact that we have, I'm going to say, unprecedented efficacy to safety ratios. So complete remission rates with these FDA-approved bispecifics as monotherapy of about 40%. That is a lot better than even what we had 5 years ago when the FDA-approved single therapies had the highest CR monotherapy rates of 25%-ish. So this is a huge improvement, and also we're going to talk about tolerability, but I would say great improvement over recent eras. Some of these patients getting complete remissions get long-lasting remissions. Probably Liz and I both have patients who've been in remission for years now, just from monotherapy, even in relapsed refractory disease. And not only that, but this therapy can be used in conjunction with other things, including being used as a bridge to other therapies, or sometimes as a debulking approach to get towards other therapies. Overall, pretty safe, and we're going to talk about some of the details of that. Okay, this was the seminal trial that got the FDA approval for epcoritamab, a little bit more than 150 patients. And the critical bits, you don't have to memorize everything on the page. You can have this quick take-home message first, that the complete remission rate was about 39%. You see that there on the far right CR column. And these were heavily pretreated patients. We'll talk a little bit more about some of the logistics, but about a third of these patients had had prior CAR-T and relapsed thereafter. We, at this point, had never had any significant prospective trials of showing any medicines with high response rates and high CR rates in patients relapsing after CAR-T cell. So these efficacy data were fairly unprecedented at the time. The responses, some of them were extremely durable. We have, for patients getting remissions, so I mentioned 40% getting CRs, but about 60% getting remissions. Of those patients getting remissions, on average, the remissions lasted almost 2 years on average. I mean, some patients were 1 year, and some of these patients are 3 and 4 years, seem to be in durable remissions. So pretty exciting that we can have long-lasting remissions from these fairly safe therapies. Glofitamab had a very similar trial in many ways. It was about the same number of patients, about 150 patients. The distinguishing features here, glofitamab, as probably folks here know, is administered intravenously as opposed to epcoritamab, which is sub-Q. And the other big distinguishing feature is the label, and the way these trials were done is glofitamab is offered for fixed duration, 12 cycles, meaning about 9 months-ish. And sometimes that can sound appealing to patients. Again, it's kind of amazing because these molecules are a bit different looking structurally, and yet at the end of the day, the complete remission rate was almost identical. It's pretty remarkable. It just shows that it's a matter of the concept of bispecifics, not so much about the details of some of the molecular structure. And the complete remission rate here was again 39%. Again, overall, the thing I would say was safer than other therapies we've had around at this time, but not completely safe. We'll get to some of these adverse events that we talk a lot about in the context of bispecifics as well as CAR-T. So cytokine release syndrome, a lot of patients had it, more than half of them had it, but the great majority had low-grade CRS, so not such a big deal. And I just think that the phrase CRS already sounds a little intimidating to some folks, but grade 1 CRS is what we kind of all have after a flu vaccine. A fever by itself with nothing else, we call that grade 1 CRS. It sounds like a big deal, but it's an acetaminophen and a go-to-bed CRS. And sorry, that's a little political because I guess we had learned recently that acetaminophen causes pregnancy or something. I didn't follow the news very closely, but there was something about acetaminophen, so I don't want to take a side on that huge debate, but it is still a medicine that we're using. I'm still, Liz, you're still, is she still?
In this context.
In this context, yeah. You get a pregnancy test for sure, obviously. Okay, before every Tylenol. Okay, so overall well tolerated, but a lot of folks with CRS, we're going to talk quite a bit about that as we go. And actually, a number of patients in this study that had icons, I won't even break down the acronym, we just call this sometimes neurotoxicity, and it can be kind of scary, even encephalopathic and obtundation, and 8% of the folks on this early trial had icons. I do think we've gotten a little better at giving these medicines, and those numbers are all a bit better in the more modern era, but still, they're not nothing. We also saw some cytopenias. Again, these heavily pretreated folks probably came in with some borderline cytopenias, but still, we saw some cytopenias even with these monotherapies. So some significant adverse events. I think that monotherapy with bispecifics was a huge cracking open of the door, but as I mentioned, the safety profile of these creates another huge opportunity, which is if you have a pretty safe, pretty effective medicine, the basis of most of medical oncology is combining things. You know, with CHOP, we cure half of DLBCL, but C don't cure no one, H don't cure no one, O doesn't cure anyone, P doesn't, but CHOP together cures half of patients. So, you know, this has been the basis of developing, we say, non-overlapping toxicity combinations. So that's a huge opportunity here because we have pretty safe medicines. So here's this next patient. Michelle is 52. She had one prior line of therapy for her DLBCL and comes to your clinic to discuss second-line therapies. So Michelle is a widow. She has 2 children. One's at college, one's in high school. She works in a bank. Her sister lives nearby, and she presents to your clinic with fatigue and night sweats. She was diagnosed a couple of years ago. She was treated with R-Polachip and completed that just under a year and a half ago. She had a complete remission, and she shows up today with those symptoms I mentioned, and on her labs, she had a high LDH, which prompted a PET CT. And Michelle's goals specifically are, no surprise, you heard she's working full-time. She has 1 kid still in high school, is to remain as independent as possible and to be active in her day-to-day life for her job and for her kids. So, I don't know what song we're going to get here, guys. I'm a little excited about it, actually. Let's hope for the best. Everyone, I'm putting it to you. What would you treat Michelle with? CAR T cells, bispecifics plus chemotherapy, GemOx, bispecifics plus an antibody drug conjugate, or a clinical trial? Talk amongst yourselves. It kind of grows on you. It's kind of,
Yeah.
A little catchy.
yeah, it is a little catchy.
Some glow sticks.
Oh, yeah, yeah. Like in a rave? Is
Yeah,
that what you kids are always talking about? Like in an airplane hangar and you go and you party? Yeah. I think I saw it in a TV show once, the one time I watched TV. So this is great. You guys heard that she's young. You heard that she was pretty healthy. And you heard that she relapsed about 18 months after her Pola-R-CHP. So we have a lot of votes for CAR T-cell, but almost the same number for bispecifics plus GemOx. That's exciting because, well, we're going to talk about why. And smaller numbers for bispecifics antibody drug conjugates and smaller numbers for clinical trials. Okay, we're going to address a couple of these with some data now. So this is, I think, a very important trial, I'm going to say, led by our buddy Jeremy Abramson, whom, if you think I'm delightful, man, you got to meet Jeremy. Oh my God, it's like me on 11. The trial was an international trial. It was a phase 3 randomized trial, primarily powered for the endpoint of overall survival, so really hitting for a home run, and that was achieved. Glofitamab plus GemOx versus rituximab GemOx, and the result was, I would say, a blowout. I think most people would say this. I showed these Kaplan-Meier curves to my baby niece and nephews, and they said, I don't like steep slides. I would want to be on the red curve. And I agree with them completely. It's a lot less scary to be on the red curve. You can see folks there. This is overall survival. Folks there living for a long time, and on average, most of them living for more than 2 years. This is fantastic. Just to go through some, it's hard to describe a Kaplan-Meier curve to a patient just in words, so sometimes we just go to some of the simple metrics, and I'll just say here, complete remission rate, our GemOx was 25 to 30, depending on the subset we look at. Complete remission rate, Glofit GemOx above 50%, and actually at a later cutoff, it was even getting closer to 60%. So you could say we are doubling the complete remission rate with the addition of Glofit here. So this was a hugely successful trial. This positive trial, again, showing overall survival benefit with this markedly improved hazard ratio. You can see there 38% improvement in the hazard ratio of dying, resulted in the NCCN recommendation of this therapy, and this triplet therapy is approved in many countries throughout the world. not exactly quite yet exactly approved by the FDA, which is something I think we're going to either discuss or not discuss. But certainly folks can ask questions about it, and we are very shy people, all of us, but we'll give opinions about it. Okay, but a hugely positive result, and I would argue practice changing as per those NCCN recommendations. The therapy was not for nothing. There were, of course, side effects in both groups, but some more side effects in the GLOFIT GEMOX group. And just to grab at a couple of those, I think, as opposed to survival and PFS, where we have unified metrics and efficacy, there's no unified metric in toxicity. You know, do you look at the nausea? Do you look at the cytopenias? What do you look at? But the closest, I think, to a unified metric is people coming off the therapy because of what they perceive as too much adverse event. So the adverse events leading to discontinuation of therapy was higher in the GLOFIT GEMOX group, almost twice as high, a quarter of patients instead of 13%. So there were more toxicities, and they were of various types. Don't go through all of them, but some of the most important ones are the obvious ones. Infections and febrile neutropenia were all a little bit higher in the GLOFIT GEMOX group. So greatly improved efficacy, some increase in adverse events. There was a similar trial done, but not a phase 3 randomized trial, a single-arm phase 2 trial. Our institution was lucky to be a part of it, so we treated a lot of folks with this regimen. Same concept, GEMOX plus bispecific, but using that other FDA-approved bispecific epcoritamab. And there were a couple other little differences. As I already mentioned, epcoritamab can be given until progression or intolerance, so people could get longer courses of therapy. And also the GEMOX was given with a different recipe. We gave the Q2-week regimen. So maybe that's good or bad. The folks got done with their chemo a bit faster, but it was a bit more dose intense, or dose frequent at least, I should say. And overall, the results here, I would say, are very similar to the GLOFIT GEMOX group of that STARGLOW trial. Again, complete remission rates here were 60%. And again, the historical controls, or even that our GEMOX control group in the STARGLOW trial, complete remission rate of 60%. That is more than twice as good as our GEMOX or GEMOX alone from recent studies. So a great improvement in efficacy with EPCOR GEMOX as well. And we even saw this in a number of different high-risk groups. Again, we saw significant adverse events, no surprise. This was not part of trial design per se, but it was a result of these two different trials. STARGLOW included some second and third line patients, but happened to be a lot more second line patients. This trial included a lot more third line patients. So that is another difference. Some of these folks were a bit heavily pretreated. No surprise, there were a lot of cytopenias and infections seen with the triplet therapy. So some efficacy for some adverse events. Overall, I think very encouraging results. And we're going to talk about if we can combine these bispecifics with chemo, perhaps we can even be more elegant and combine them with other new novel targeted agents. So this is something getting towards that. We call this the SUNMO trial, a combination of mosunetuzumab, again, FDA approved for follicular lymphoma, not FDA approved for DLBCL, but here being used in combination with polatuzumab. Pola, you all know, antibody drug conjugate targeting CD79, approved in frontline DLBCL, approved in later line DLBCL, all in different combinations. So Mosun Pola versus that same comparator, our GEMOX for relapsed aggressive B-cell lymphomas. The trial design you can see here, a 2-to-1 randomization, and going to the punchline, huge benefit in progression-free survival. I did not ask my niece and nephews about this one, but you can imagine that they would like the green much better. So there's a huge benefit here, a drastically significant p-value. This is progression-free survival. We do not yet have a benefit of overall survival in this study. There was a trend towards it. The numbers of this trial are a little less, as you can see, about 200 patients in total in the trial, so it might be a bit underpowered. PFS was the intended primary endpoint. So a huge success again, and you can just about call this a chemo-free regimen. Polatuzumab is an antibody drug conjugate, but pretty well tolerated. So chemo versus a nearly chemo-free regimen, and a huge benefit by adding that ADC to bispecific antibody. Again, showing that data, but just by response rates, and you kind of see the same thing I showed you with chemo. Adding antibody drug conjugate, we are doubling the complete remission rate of our GEMOX. You know, CR is not a bad surrogate in DLBCL. It's kind of win or go home in DLBCL. Most of the PR is not very durable responses, so at a quick glance, CR rates are pretty telling. And a doubling CR rate, no surprise, the PFS was so much better. Overall, this regimen, I have not used a lot of Mosun Pola. Liz, have you used a lot of Mosun Pola?
I've used it a couple of times. I have a colleague who particularly likes it. And it does seem like it's incredibly well tolerated. And I think one thing is nice too is we had a patient recently where they were in the hospital and somehow I convinced the pharmacist to let us have a dose of Pola. So we got the dose of Pola in them, kind of got them under control, debulked them, and then they kind of sailed through the Mosin part because they'd already been a little bit debulked.
It almost looks too good to be true, and yet everyone I asked, I've only used a little bit of it. We were not in part of this trial, but everyone I asked, they said, no, it's as easy as it looks. And the appealing part in theory, let's be honest, community docs have a real problem with some of the bispecifics because of the mandatory or recommended hospitalization. And once we move to Mosin here, no mandatory hospitalization. So this is a big deal for ease of use for community docs, and also a big deal for patient quality of life, avoiding hospitalization. So that's why this is kind of elegant, and the efficacy you see, but the safety has been quite remarkable. Very few CRS events at all, and almost no high-grade CRS events. Overall, very well-tolerated regimen, and again, just about chemo-free, so that's pretty cool. Okay, combining bispecifics with antibody-drug conjugates has now become a recurring theme, and this LOTUS-7 trial, for me, came a little bit out of nowhere this summer when we saw the results. I think I knew it was ongoing, but I didn't know the data was as awesome as you're about to see. So this combination of glofitamab with loncastuximab, CD19 antibody drug conjugate with a different payload, tesarin, so a little different than these vedotin payloads that we've talked about before. Fairly simple trial design so far, single-arm trial trying to tweak the best dose of the loncastuximab. I won't go into more detail of the trial design because the punchline is here, and it is, I want to say, unprecedented. I got to go to Merriam-Webster, make sure I'm using that word unprecedented correctly, but I've never seen nearly 90% CR rates with, again, what you might argue is a chemo-free regimen, antibody drug conjugate plus bispecific antibody. So here's the catch. Small study so far. This is just 30 evaluable patients. This trial is continuing to accrue, and we're hoping to see more data very soon to see if, even if it's still not 87% CR rate, it still has to be extremely high as we add the next 70 patients to the trial. So not so surprising. We don't really think that, although we sell a lot of, synergy, greater than additive benefits of A plus B, I don't think we normally see it. But this antibody drug conjugate plus bispecific thing really seems like you're getting a greater than additive benefit because these CR rates are pretty unprecedented, and some of these patients have been in remission for many months and some of them years. So amazing efficacy result. I won't go into more detail of the LOTUS-7 because it's still a pretty early trial, but just a glimpse at the future. Okay, so just real world. Liz, we talked about all the different options that we've seen for Michelle and for Henry. But broadly speaking, third line DLBCL, are you a bispecific monotherapy person? Are you, for most third lines of CAR T, we talked about Henry and he should still be considered for it, or are you more of a bispecifics plus chemo person? Or you're not so simple?
I mean, ultimately, it comes down to the individual patient. I do tend to, I think, come into the discussion with a touch of a bias toward CAR T if I do think they're CAR T eligible, because at the end of the day, that disrupts a patient's life for 2 to 3 months and hopefully gets them a durable remission, right? So in terms of just sort of something that's incredibly efficacious, and you could tell me what you think about the patient perspective, but I feel like in some ways that's an easy way to say, hey, this could work incredibly well for you. There's potentially curative potential. Yes, it's going to disrupt your life in the beginning, but it might be worth it in the long term. But you have plenty of people who don't want to do that. You just start explaining to them some of the toxicities, and they don't want to touch it with a 10-foot pole, which is where the bispecifics have been incredibly helpful, because now you can offer them that option as well, versus where in the past we'd be reaching for, based on cell of origin, maybe we're going to give them BTK, some sort of lenalidomide combination. I think where a lot of us sort of don't know the answer, but I think as more data comes out with more plateaus, which is whether or not there's truly curative potential of bispecifics. And I think every time you see another data readout that's a little bit longer and still has that plateau, you start to go, oh, maybe there is a subpopulation that is potentially cured with this.
Your last 10 patients, bispecifics monotherapy, bispecifics combinations?
I think a lot of it depends on their degree of how ill they are. I think that factors in a lot. For me, unfortunately, a lot of these people are coming through the hospital, and I can only do so much in that setting. So there's been a lot of give the GEM-OX, and I'll add the bispecific when they get out. So there's a practical piece to that. Yep. For those who we get to sort of figure it out in the clinic, and they don't get sick enough to go inpatient, I think I still do talk about adding the chemotherapy. I think if nothing else, and we treated some patients on not Starglow, but a different chemotherapy plus bispecific study, and I do actually think the debulking with the chemotherapy does help you in terms of the CRS risk. Yeah. So if somebody is able to tolerate a little bit of chemo, it is, I think, at least worth considering.
It sounds like for a good chunk of them, you're thinking about combo more than just monotherapy. I was taught by my sister never ever ask a woman about her age, but can I ask you about your formulary? Is that okay? Are you comfortable with that?
I could talk about that. So we have to put certain drugs on formulary, and actually early on in the bispecific era, I actually made an argument that I wanted to have everything, because I don't know that I feel this way anymore, but at the time I sort of felt like there was a GlowFit patient, there was an EPCO patient, then obviously I wanted Mosin for follicular, but I think as time goes on, as we're getting better with recognizing the CRS and managing it, like I used to be worried that there was more CRS with GlowFit and kind of lean away from it for certain patients. But as time goes on, I'm less sure about that. But we're also at an institution that is not necessarily like if it's not on formulary, I can't use it. So it's just a matter of giving pharmacy enough leeway to order a drug.
If you bring them like donuts or pastries, the pharmacy, I find you can get a lot more. It depends, I'm sure, on the pharmacist there that day. And specifically to this question, because you already sort of said this, but I want to put you on the spot. So you said I want to be a real open-minded about trying to get people CAR T. So is there, and again, it's all individualized, personal for each patient. But is there a certain type of patient who definitely has to be a CAR T patient before a bispecific?
I mean, at the end of the day, if the patient doesn't want to do it, I'm not going to make them. But I do think for the younger person with bad disease biology, I would feel better about life if we got them to a CAR T and saved the bispecific for backup.
And do you have any strong feeling about how much you encourage them for CAR T if they're a second-line early relapser versus some third-line, maybe late relapser?
I mean, obviously the data would suggest that second-line early relapser would be much better served by CAR T. Now, the problem is we don't have a ZUMA-7 study of bispecifics to necessarily know that for sure.
Yeah, a Zuma Star 7 glow or something like that. Yep. Right, but compared to old platinum in auto transplant, a huge benefit to CAR T in those early relapsers or transform for lysocell. Okay, yep, sounds like it is personalized. We do not want to be neglectful of CAR T. I think in Irvine, the 82-year-olds are probably healthier than some of the 82-year-olds.
I've got some decent people in their 80s, and I've taken some of them to CAR.
Well, you have all that fresh air over there. I think that's a big part of it. Okay. Probably the most important part of all this, because we, in medicine, we are a service industry. So yeah, who are we serving? Hopefully the patients. So we're going to talk a bit about patient perspectives, and you've got a guy there, yeah.
Yeah. So I think that one of the really big things to keep in mind is as our patients progress through their care pathway, yes, efficacy, safety, they're still very, very important. But everything comes at a personal cost. So every time you give a patient a treatment, they're dealing with the toxicities, they're dealing with those side effects, but they're also dealing with the impact that their disease and care has had on their quality of life in other ways, right? That they're missing work or they're missing time with their family, that they have a care partner at home, and are they also missing time at work? All those kinds of things come into play. And we know, if you have a first-line patient who's never had any care, yes, they want to be cured because they don't know what it feels like to actually go through those side effects. You can tell them, this is a possibility, this is how it might impact your quality of life. But once they know, their opinion's different, right? And so what's really important is when you're having these discussions, and we can be very clear, these should be discussions with the patients. When you have a choice, your patients should have a choice. And your patients want to have those choices. This is our survey. We were, in this case, looking at those that were relapsed refractory one-time diffuse large B-cell, and almost all of them want to participate in decisions about their care. So this is not a question of, or do my patients really want to be into this? Yes, they very definitely do. But only half of them are feeling as involved as much as they want to be in those decisions. So there's some big gaps here in making sure and having even that dialogue with your patient. Like, do you want to be involved in these decisions? Is this meeting your needs? What else do you need from me so that you feel like we can make this decision together? I will also say regardless of what you tell them in the clinic or how well you think you're informing your patients, almost all of them are going to go look for more information. And there's lots of reasons for that. They would prefer, I will be very honest, up front, they would prefer to get their information from their doctors. They would prefer that they could have really good conversations with their medical team, and they would get all the answers to their questions. But in reality, that doesn't happen. And it doesn't happen for a lot of reasons. One, yes, you may have time limitations in the clinic, for sure. They may not be feeling too well the day they come in, and they're just like, oh my gosh, I just need to get this done. What else happens sometimes is they ask you a question, you give them an answer, and they have no idea what you're talking about because this language is all new to them, but they don't want to tell you, I have no idea what you just said. Anyways, whatever the reason is, at the end of the day, Dr. Google and Dr. AI now are their friends, right? And usually when they're going and they're looking for more information, I will be honest, most of the time they're ending up ultimately on a patient organization website or information coming from a patient organization. But they are going and looking. And so, you know, that information that they're learning, they may or may not tell you, even though it is influencing the decisions that they're making about their own care and how they're coming back and talking to you about their disease. What's also really important, though, as, like I said, a patient in first line has, you know, I've never had this happen before. I don't know what chemotherapy feels like, but now I've had chemotherapy or now I've had that first line treatment. Cancer therapy, I don't really like it. And so what happens is their idea of what is important to them in their next therapy changes every time they get therapy. So this is a relapse refractory first patient group from the survey. And you can see that a cure is still vitally important, but it's equally important here is an improved quality of life. That's the difference we see. Now I know what this feels like. Now I know how disruptive this is on my quality of life. Now this is becoming more important. So when you're having those discussions with your patients about their choices, be really, really thorough on what those side effects might be. So when we've looked at these two patient groups, you know, and CAR-T may raise to the surface for some of you treaters, if you go back and look at some of those patient profiles, like you have a female that's younger, medically may fit for CAR-T, but it actually says that she just wants to get back to her life, right? She doesn't want to have too much disruption for her life. CAR-T is disruptive. It may be a short-term disruption, but it's disruptive. So, you know, that you really, really need to go back and have that conversation, even though medically, you know, we think this is good, it's potentially curative, this might be what I think is the right choice for you, really giving them a look at their other options. We've done some interviews of patients that have had CAR-T and have also had Bispecs. And we actually find a lot of younger patients have gravitated toward the bispecifics because of the disruption that they see with CAR-T, as well as the intensity of the side effect profile, and then the long-term impact on their quality of life. So just because you think something is medically great, when the efficacy is very, very similar, go back and ask your patient. You can see as well, you know, you get into the other end of this chart when we're talking about duration of treatment, for instance, or impact on care partners, that those have less importance. But I'm telling you right now, if the efficacy for the therapies that are options for the patients are equal or very, very similar, these things become really important. So even though they may not look really high here, if the efficacy is the same, then they're looking at how long do I have to have this treatment? How long am I going to be in the hospital? What is the onus on my care partner, right? Like what's going to happen for them here, and what am I going to put somebody through? So it's really making sure that these decisions are done through a lot of open, honest communication with your patient to make sure they're getting to the treatment that's right for them.
Lorna, may I ask you mentioned Dr. Google and Dr. AI. Do we have like granularity from this data of, is it Google, is it ChatGPT, is it Facebook, oh my goy, is it Twitter, or do we know, or is it all, you know, Leukemia Lymphoma Society or something like that?
Yeah, so truthfully, most patients are on Google still. There is some variety depending on age, right? Social media is big. Depending on your age bracket, you might, if you're older, you're on Facebook. If you're younger, you're on TikTok. Don't forget the TikTok. And you know, AI is definitely increasing, not on this present survey that we analyzed for this particular presentation. We have a survey launching in January, and that has a whole big section on AI and exactly not only if patients are using it, but how they're using it and if they're validating the information with their healthcare professional or any other source, because we know, you know, good and bad on the internet. It may be a shock to you. Not everything on the internet is true. And so, you know, we have to be able to help point our patients to good resources because sometimes they can't tell what's good and what's not. They may be on a great, what they think is a great patient group discussion, but yet you'll get those patients who have heard something about ivermectin and they think that this is the answer for everybody, or they just need to take, you know, smoke some pot and they'll feel better. So it's really, you know, encouraging, asking your patient, like, have you read some other information? Have you looked up other sources? Let's have a chat about what you learned. But don't, by the way, disqualify. There'll be some patients that will come in with clinical studies, right? Like they're all over looking into journals and learning how to read those clinical studies so that they feel really well informed about those choices that are available to them. They might teach you something. So really have those good conversations.
Yeah, I mean, if it's Facebook, then my aunt is telling them about the ivermectin, and I feel bad about it.
As well as what you did when you were 10.
Yes, that's even more awkward. But wherever they are, we do a little bit if it's social media, we have to try to meet them where they are. Because if they're on Facebook, I can complain about it, but you know, we have to have LLS or Medscape or everyone go to Facebook and, you know, be a presence there so we can maybe get a little less of the ivermectin, and bring back the acetaminophen. Okay, Liz, do you have a button? Oh,
I do. I'm ready. All right. So part of this shared decision making is going to be based on both short and long-term toxicity. So there's two cases here. One's sort of the early side effects, and the second one is the late side effects. So I think I'm not going to spend too much time here. When you're looking at the different bispecifics and trying to decide between one or the other or whatever's on your formulary, they have slightly different recommendations in terms of how we kind of avoid some of these early toxicities, but it basically comes down to pre-medications and then having the correct tools available to you after the fact. So you do not need to memorize this, but the general theme here is, you know, the recommendations are for acetaminophen, some sort of antihistamine. I hate diphenhydramine, but that's a different story for another time. And then some sort of steroids. And this is actually really where the labels for these drugs diverge. You've got mosunetuzumab, where it's kind of just a one-shot deal. The epcoritamab recommendation is a little bit more complicated because there's actually 3 days of steroids to try to prevent the CRS. And then the glofitamab, you can see their recommendations there as well. So again, not necessarily something that needs to be memorized, but just to know this is all in the PI, but sort of the things you want to talk to your pharmacist about when you're building these treatment plans if you don't already have them built. So afterwards is the scarier part, because then they're no longer sitting in your infusion center where you have complete control over the situation. So here's our patient. He is 71. He lives in an apartment. They have 3 stairs. He just started his bispecific antibody for third-line therapy. He has hypertension. He had both of his knees replaced and a little bit of peripheral vascular disease. He's in pretty good shape with an ECOG of 1. Unfortunately, he speaks very good English, but his wife doesn't. So if she has to call when there's an issue, it's something you have to keep in mind. Son lives in the same town, but he's not exactly next door. He got his EPCO 4 days ago. He's been tolerating it so far, but for some reason with this dose, he's calling the on-call fellow at the middle of the night saying he has a fever. His wife is doing her best to try to describe his symptoms to you, and he is complaining of fatigue and chills. So we now have, let's just say you send him home with an ambulatory monitoring kit, and he can tell you that his temperature's 38.5 Celsius, a little bit of tachycardia, SAT is not terrible, but down a little bit, blood pressure soft, but not awful. So you're sitting there, or their fellow's calling you, and you're trying to decide, is this person infected? Are they having CRS? Is it even both? And what would you like to do with him? Would you like to send him to the local emergency room? Would you like to have him take some Tylenol and call you back in a couple of hours? Would you like to send him to urgent care even though it may or may not be open? Or did you send him home with what we like to call pocket dexamethasone, and he's going to take that 8 milligrams of dexamethasone you sent him home with just in case he had CRS, and he's going to take it and call you back?
Yeah, the glow sticks. Yeah, I could totally
Yeah,
see
right,
that now.
yeah.
Yeah. No, that would actually be really relaxing. I mean, there's no wrong and right answers, but there's
There's
some
not a
righter
wrong-
answers and
Yes.
wronger answers.
I would agree with that. All right, so if a handful of people want to send him to a local ED for infectious workup and possible TOSI, I don't think that's ever the wrong answer, especially if you're trying to triage something in the middle of the night and you can't exactly tell what's going on. There are also a handful of people that want him to take his pocket dexamethasone and call you back in an hour. Fewer people are excited about having him take some acetaminophen or going to urgent care. And I think, like I said, I think option one is never the wrong answer, especially if you're just really not sure what's going on. And I think in this case, particularly the borderline saturation and the borderline blood pressure kind of could skew you a little bit towards option one. What do you think?
So, I mean, he's day 4. So actually, it's a little on us because we neglected to say which dose of Evcor this was, but I happen to know this is actually a buddy of mine's patient, and this was day 15, cycle 1, day 15. So this is the one that you can get CRS. Still, day 4 is not unheard of, but it's well past the median, right? So you have to, therefore, a little bit down titrate the likelihood of CRS and up titrate the likelihood of something else. And, you know, he's not a baby, and grown-ups get infections, and lymphoma patients get infections. And if you miss what here would be probably still a grade 2 CRS, no harm, no foul. If you miss pneumonia, that can be bad. Yeah. So I like the fact that the majority of the folks here are sending him to the ER. It's not great for quality of life.
No.
That's why we don't do it for everybody. But yeah, for Hisham, I like that, yeah.
I guess it also shows us the power of ambulatory monitoring that we had all those sats for him, huh?
Yeah, pretty cool. Actually, I think that's COVID is to blame. You know, everyone went out, Amazon.com. Sorry, I don't work for any vendor you can buy them from. It didn't have to be that one that I just mentioned. And yeah, O2 sat for sure. If your iPhone or your watch or something doesn't tell you, don't trust the watch for some of these, because we tested a lot of them next to real O2 sats and all that. But yeah, and that for me was the thing, was the day 4 and the 93% sat. You know, Hisham lives at 98 and 99 usually, so 93 is not quite right.
All right. So I think that particularly if you are new to the using of bispecifics, you haven't introduced them into your practice yet, I think the toxicity piece is the thing that maybe makes people a little bit anxious, right? And I think in particular because it's the CRS, the cytokine release syndrome, and the neurotoxicity or ICANS, just because they're unique, they're different from a lot of the other things we use day in and day out in routine clinical practice. You know, the cytokine release syndrome is to some degree, it's a mechanism of how these drugs work, right? The whole point of this is to activate T cells, and sometimes when we activate T cells, we get fevers. So it makes sense. And for the most part, they end up being low grade, as we sort of have talked about, but it can be bad, and it's important for us to recognize this. And I think a lot of this becomes when you're educating the patient not only about the treatment decision, but then once you say, okay, we are going to do bispecifics, when to call me and when to be worried is a huge part of that conversation. So if you want to look just broad strokes, now obviously there were slightly different eligibility criteria for all these studies, and they're slightly different populations, but nonetheless, at the end of the day, I usually just tell people you're going to get a fever, because 50% of the time they do, so they might as well be emotionally prepared for it so they don't panic. But if you look at how severe the CRS is, most of these drugs, most of the CRS is grade 1 and grade 2. You can see there in the last column, there are some events of high-grade CRS. I do feel like as time goes on, the rates seem to be lower in subsequent studies, and I think that's more about familiarity, both for the treating doctor and for the patients. And I think in the early times, we got a little anxious when we gave that steroid. And I think as time goes by, we kind of understand how important it is to just nip it in the bud early. So it does feel like as time goes on, when things read out, these rates of grade 3 and higher CRS tend to be lower. So for epcoritamab specifically, we just sort of talked about this. So this is the big dose is on day 15. There is in the package insert consideration of hospitalization. Every center does this a little bit differently, but many of us do still hospitalize our patients for brief observation on the cycle 1 day 15 dose, because that is when the CRS is likely to happen. As we talked about, it usually happens really quickly, onset being 12 to 24 to 48 hours, and it is, again, most common, at least for this particular drug, the day after the day 15 dose. But most of it happens early. So usually I kind of tell patients we're going to monitor you a lot in the beginning. Once we get to month 2, if this hasn't happened, it's not going to, and we can be a little bit less cautious. For glofitamab, again, all these dosing schedules a little bit different. Don't memorize them. You can always look them up. But for glofitamab, it's the day 8 dose that's the big one that has the higher incidence of CRS. Interestingly enough, that's not the biggest dose. The biggest dose comes later at 10 milligrams. But for whatever reason, this drug, you tend to get the bigger dose. And that's because day 1 is the obinutuzumab, and then the first real dose of glofit is on day 8. So again, recommendation in the package insert is to hospitalize patients for this particular step up. Again, it happens early, medium time onset here, about 13 hours. And again, if it's going to happen, it usually happens for the most part during cycle 1. In this case, because cycle 2, day 1, there's another step up to that 30 milligrams. You can still see it in cycle 2, and then for the most part, the CRS drops off. So what are the tools that we have to manage CRS? Again, we're going to pre-medicate them when they're getting it, right? You're going to get your acetaminophen, you're going to get your hydration, we're going to monitor temperature, we're probably going to give some sort of steroid prophylactically. Then the question becomes, where and how are you going to monitor patients? Like I said, for certain step-up doses, there is at least the consideration of hospitalization. If you happen to have a very savvy patient who literally lives next door to your hospital and you have wonderful availability of MP support, maybe you could do it outpatient, but that really requires having a really good team and a really good mechanism in place. And so I think every center has sort of figured out their own way to do it with their own personal resources. I think in general, we're all trying to avoid utilization of the emergency department for obvious reasons. And so I, for example, will often bring people for kind of infusion center visits to get their vitals monitored, give them fluids so I can kind of get ahead of anything. When you get these drugs on board, one of the things you want to make sure you have is tocilizumab. I think we're very comfortable with giving it. That being said, even though this here says consider early toci, I actually can't remember the last time I gave toci for a bispecific, because I think we're so quick with the steroids, we often don't even get to the point where we need the tocilizumab. But please have it around just in case.
Yeah, I mean, it's like low double digits or something. Yeah, it's not half, it's not a third of the patients, it's probably not a quarter. Yeah. And yet, I don't know nothing about myeloma, but I know some of my myeloma buddies are giving like prophylactic toci for those, which again, I don't think is highly cost effective since most don't need it. So the community and academia, even some of my community buddies say, I will do whatever I need to do to make sure they don't come back to the hospital because the hospital's full, ER is not, is busy. But yes, I've not given a lot of toci recently, except we're not talking about mantle cell lymphoma will be a thing one day, and a lot of toci there.
It does seem like the circulating diseases are a different beast in that regard.
Yep.
Okay, so then we have the CRS risk, then we have the infection risk. We are depleting B cells, whether or not they're lymphoma cells, we are depleting B cells here. So, and in addition to that, we're also affecting the T cells in a way that we don't necessarily affect it with other therapies that we give, right? And we're giving steroids. So there's a lot of mechanisms at play by which we could be really setting people up for infection. And for better or for worse, we did a lot of these trials during COVID, and we were keenly aware of the risk of viral infections in particular. So we talked about multiple myeloma. So part of the reason to bring this up, I think, is twofold. I think we had a little bit more time. Some of the multiple myeloma bispecifics got approved really early, so they gave us an opportunity to get really comfortable with this class of agents. But it does also seem like the infection risk does tend to be a little bit different in that population. So I think some people might have used, for example, teclistamab, and then the patient had awful infections, and so maybe they've been a little bit anxious about, for example, giving that first patient epcoritamab because they're still scarred from the infections that their myeloma patients had. So it's not just as simple that all bispecifics are the same, and it's certainly myeloma patients and lymphoma patients are very different in terms of prior therapies and their status of their immune system. So this is just to say that the risk of infections isn't nothing with the lymphoma drugs, and we'll go through it, but it's not quite the same as what you might have experienced with some early endeavors with things like teclistamab and elrantamab. So obviously, we would like to prevent infections rather than deal with them later on. So, here it says, vaccinations. I think that gets a little bit complicated. Sometimes you don't exactly have enough time to go send somebody to get their flu shot before you start. But if you have time, great. You do need to screen for things like Hep B, just like you would before rituximab. Maybe if somebody has been heavily pre-treated, maybe if they have an EBV positive lymphoma, you might want to look at some of those things. You may also, if there's somebody particular risk of TB, maybe you want to do some sort of assay for that beforehand. PJP prophylaxis is not totally mandatory, but a lot of people do it. And in particular, I think a lot of people like to do it in the very beginning when you're not only ramping these drugs up, but you're giving a lot of steroids to try to prevent the CRS, right? So I think that's relatively common that people are employing PJP prophylaxis. Varicella, I'm a very liberal user of varicella zoster prophylaxis. Some of my colleagues aren't. As I like to tell patients, you got enough going on, you don't need shingles on top of it. So then in surveillance, right? So we're aware of the infection risk. We're going to educate the patient. We're going to throw appropriate prophylaxis at patients. So then how do we keep an eye on them sort of after the fact? So one of the things that we're sort of learning, and now that we've had these drugs a little bit longer, is to what degree the B cells are depleted and what are the kinetics of them recovering. So this is a really lovely poster that's going to be presented on Monday night looking at mosunetuzumab, and this is a fixed duration schedule. So these patients got about 8 or 9 months of therapy. So maybe not surprisingly in figure A, up until about 9 months, there's just the B cells are way down there, right? There's just no B cells. But you can sort of see that as time goes on, there's a slow recovery of that B cell compartment. And it takes, about a year or up to 2 for those B cells to kind of totally recover. So we now kind of can look at some of these kinetics to help educate people, like the last week, when can I do this? When can I do that? When is my infection risk going to be lower? Now we have a little bit more information to help guide that. Interestingly enough, it seems like the T cell compartment is not quite as affected as the B cell compartment, at least when you look specifically at the CD3 positive T cells. They were relatively, in this data set with mosunetuzumab, they were relatively well preserved. So what's one of the other ways you can look at it, right? So in my clinic, I'm not going to routinely go measure B cells outside of a lovely clinical trial like we're looking at here. What I'm going to do in my clinic is I'm going to measure their IgG level, right? Which is a little bit of a surrogate for their B cell level overall. And what's interesting here is that the IgG dynamics seemed a little bit different than looking at the B cells when I think they flowed by, say, CD19 expression on that prior slide. So it's worth kind of keeping an eye on the IgG levels, but it's interesting that doesn't completely match the dynamics of the B cells. Interestingly, maybe even more accurate with sort of the IgM level, where you can see it really does kind of bottom out about 6 to 9 months in and then does slowly recover. So interestingly in this, if you're going to use a surrogate marker to track the B cells, at least in this data set, it actually might be IgM's better than IgG. So in terms of patient perspectives.
Thank you. So in this chart, we're actually looking at data cut for relapse refractory at least 2 times. And why this is important is you can see that there's a change in what the patient thinks is most important to them or what they're prioritizing when they're choosing their next therapy. So it's just proving that over time, patients become less and less focused necessarily on that cure and really about how they are feeling overall. Because now the most important thing is quality of life to these patient group overall. And really that's just something to keep in mind. We've talked about the fact that there are lots of different treatment options now with similar efficacies, and that patients want to be involved in those decisions. Yet when we're actually looking at the patient population and asking them, did you get more than one choice of therapy, you'll see about 40% actually did. So that leaves a lot of patients that are not being given a choice. Even when we explore that a little bit more, we did go back and ask them about the types of choices that they were given. And they were like, yeah, sometimes, my doctor gives me a choice, but it doesn't really feel like a choice to me. So for instance, when we interviewed patients with CAR T, they said sometimes their choice was CAR T or palliative care. We didn't interview one patient who told us that their choice given to them was a CAR T or bispecific, right? It was CAR T or stem cell transplant, it was CAR T or palliative care. So really, it's like there are so many different options now. Let's really look at what is best for that patient and give them real choices. We have really activated patients sometimes who will go and find new trials for themselves or look at, and find different information and come back to their doctors. But that takes a lot of confidence for a patient to be able to do that. Oftentimes what's happening is a patient behind the scenes is, talking to their family and friends going, oh, I wish I could do this, but they're not vocalizing it to you. There is, again, that component of that patient-doctor communication and how vital that is and how welcoming the doctor appears to be for valuing that patient perspective. Patients tell us for the majority of patients, they do say that when they're talking, their doctor interrupts them. If you interrupt them a lot, they feel like whatever they're saying to you is not important. They do say sometimes when they raise things that are impacting their quality of life, they get minimized. And so they think that they shouldn't talk about those things anymore, that you're not interested in them. They say that, they have questions to ask, but there's no time in the appointment for those questions to actually be asked. And so all of those things are impacting a patient's confidence level, and they're less likely to vocalize to you what's really important to them. So really thinking about those clinical behaviors you have when just in your open conversation. Think if you tried this at home with your spouse, how welcoming they would be to that kind of conversation level. Just really rethink how you're having those conversations to really encourage the patient to be fully honest with you about how they're feeling, what the impact is on their quality of life, and what they would like to see next in their therapy. I just want to say really quick, because we're talking a lot about DEX. DEX comes with its own slate of adverse effects. Make sure that you're not only talking to your patients about the adverse events they might see with the main cancer therapy itself, but those supportive care or other treatment mechanisms that you're talking about those as well. We have patients that come to us at patient groups all the time and are like, why am I so hungry? Or why am I so angry at the world? Oh, yeah. And it's like, are you on DEX? And they're like, yeah. And so really think about that broader picture, because they just think of it all as treatment, right? Like they think you've told them everything that they need to know, and don't know that it's limited to like a certain portion of their therapy. So really give them all of the information so they do understand what the impact is going to be on their quality of life.
Okay, so many of you have some amount of experience with bispecifics. So I guess I'm going to ask you, if you haven't utilized them in your practice, I would like to know why. And I guess maybe if you are a prolific user of bispecifics, maybe I'll ask you if you know of other practices or colleagues who haven't utilized them, if you're aware of why. So maybe it's because they don't see these patients. You probably do if you're in this room, but just in case. Maybe you're just worried that you don't have the help to monitor if somebody calls with a fever, or you're not going to have somebody to support you. Maybe you just have more comfort with some of the other things that came before and you feel like they work really well. And I suspect with the amount of time we spent on the data, it's probably not 4, but if you're still not thrilled about those CR and response rates, you can feel free to answer 4.
Dr. Brame, I don't want to interrupt people from answering. Let's do this, and I'm going to ask you a question that came in.
So there are some of you who are here to learn, even though you don't see these patients. So thanks for coming to learn with us. There's about a 23% of patients who just sort of feel like they don't have the infrastructure, which I think that's a reasonable fear. And sure, if you got really comfortable with polatuzumab BR, that is a very easy therapy to get, and I could imagine it'd be hard to then swing towards worrying about people calling you with fevers in the middle of the night.
Liz, just because you mentioned a couple slides ago preventative things, prophylactic things, and you even included CMV PCR monitoring. So we got a question from the audience from Andre Bernardelli. Do you monitor CMV DNA in your practice? In our experience, we've encountered 2 symptomatic CMV reactivations that require treatment. So the question is monitoring, yes, no, if so, how much? You can give your answer, I can give my answer.
You know, I think maybe my cell therapy colleagues are maybe a little bit more aggressive with their CMV monitoring than probably I am. But that being said, just this discussion is making me kind of think maybe I'm going to start checking it at baseline before I start some of these therapies on patients, because then if they do call you with diarrhea, it does help you kind of triage what's going on, and your brain might go to CMV reactivation a bit faster. If I know they have it, I'm probably checking it about once a month. I've had more personally experience with CMV reactivation, honestly, in the myeloma patients, because I do treat some myeloma, than I have in lymphomas. But I do think probably, yeah, monthly, if I am monitoring it.
I feel like in the studies, we did a ton of CMV PCR monitoring. I felt like and not just monotherapies, but combo with chemo and everything. And I felt like I saw very, very little, and the data kind of goes along with it. And occasionally when you see a positive PCR, it's an asymptomatic,
Right.
you run to your ID call, your infectious disease buddy, and say, do I do something with this number? And they say, no, that's barely positive. So, you still needed a symptom kind of to treat. So now I'm unsure. I kind of think, you know what, let me just watch for symptoms. No diarrhea, no fever, no nothing. What am I even going to do with a positive result? So I'm not routinely doing it across the board, though, but there may be a better answer than that. Because the question is, how many do you have to send to get a positive one? I feel like you'd be sending dozens or hundreds to get a positive one. And, should we be checking our patients' LDL cholesterol every day? No, I mean, some of them, we're overdoing some of the tests. So I am curious. Andrea, if you can chime in, if it was a myeloma bispecific or a lymphoma bispecific, let us know. I'm super curious. But she had to treat a couple of them, so that is interesting.
Good questions. All right, so now we're going to, although I guess we could argue that CMV reactivation could be a late toxicity.
Yeah,
so that's
yeah,
a nice segue to
Beautiful.
our next section. Look at that.
I sort of did it on purpose.
So we have another relatively young patient here. She has been receiving glofitamab for 6 months now. She's a middle school teacher. She already got POLA-CHP. She got her CAR T, so this is third-line therapy for her. She had a PET while on therapy that looked great. However, she's struggling a lot with infections, which maybe is not a massive surprise since she's a school teacher. She's had 2 bronchitis episodes. Now she's got pneumonia. She's got her steroid inhaler and some levofloxacin. You check her IgG level, it's 350. And she's a little stressed out about this, like, should I take a break from teaching? Am I going to get sick again? Am my next pneumonia going to put me in the hospital? Which I think are real patient concerns. So when you're sitting down with her and listening to these concerns, what are you thinking? She's going, well, I just can't take the time off. I've used up all my sick time. I got to go. So what do we do? Are we going to monitor her IgG levels twice a month? Are we going to stop therapy because she's in CR? Are we going to throw prophylactic antibiotics at her? Are we going to do IVIG? Kind of wish we could have put multiple choice or multiple answers for this one, but nonetheless, pick your favorite, and let's see what we're thinking.
I think when I was a kid, my mom used to sing me that song when I was going to bed. That's why it sounds so familiar. Yeah,
Bedtime song.
It really helped.
All right, so about half of the people want to start IVIG, which was personally what I would be doing in this situation. Whether or not it would be wrong to give her more antibiotic prophylaxis, probably not. We should definitely be monitoring her IgG levels. Twice a month, I think, might be overkill. Very few of us wanted to stop the glofitamab, and I would argue I think that's the correct choice here. To continue, sorry, the correct choice to continue. I want to be clear about that. So we talked a little bit about kind of those B-cell dynamics and, hypogammaglobulinemia, and this is one thing that is universal, whether you're treating multiple myeloma, follicular lymphoma, or large cell lymphoma, you're going to be dealing with hypogammaglobulinemia when you're treating patients with bispecific antibodies. I do check them probably about once a month for most of these patients, because especially since if you think about somebody like her, right, she had Arapola chip, she had flu-cy before her CAR T cell, like she's kind of ripe for hypergammaglobulinemia. I'm also very generous with my IVIG repletion. I don't always necessarily do it the first time their IgG level is 300. I often wait to let them get an infection, but in her case, right, she's had bronchitis twice, she's got pneumonia. This is a perfect patient for just kind of giving them prophylactic IVIG. And if the bispecific is still otherwise helping, you do want to treat through it and just give the IVIG on top of it. You know, it's the other thing to keep in mind too is like checking serologies is then going to be complicated, right? You've just given them IVIG, so probably a lot of serologies are going to be a false positive. So if you are worried about, for example, CMV, you should be checking a PCR. I don't particularly do these baseline serologic testing. I guess you could, but not something I do routinely other than, again, Hep B prior to starting therapy. Although I guess from the patient perspective, that's the one thing I always feel bad about with IVIG is I am asking a lot out of the patient to come sit and get IVIG for 3 or 4 hours every 4 to 6 weeks. So I am cognizant of that, but that's how we avoid the repeating cycles of infections.
Much sub-Q IG?
So if anyone is practicing in Southern California and knows how to get it covered and administered, please let me know, because I recently tried to, and I just like could not figure out logistically how to do it. What's been your experience in New York?
Yes, sometimes we get it covered, no problem. But like with a lot of coverage stuff, who knows less about coverage than a doctor? So I couldn't tell you the pattern. But yeah, some of them got it covered. They do injections to them. I mean, they're just doing their Ozempic, their sub-Q IG. They got a whole bunch of needles lined up. Their Dupilumab. They've got everything ready to go. And then sometimes I think we tried and might have failed. But yeah, it's a schlep. It's frequent, and it goes on for maybe easily 12 months. So it's a lot. Some of these people are still getting their therapy, their GlowFit, their whatever, and we don't know what the right practice. But we tell them, you know what, don't get them on the same day, even though we don't know the right answer. So they're coming in like every 2 weeks now for a GlowFit and IVIG.
That's interesting. I don't necessarily separate them.
You give them same day.
I do give them the same day.
I think we actually had someone tell us without any quality data, oh no, we recommend these be separated. And we said data, and they said, yeah. So we have done it sometimes. Yeah, a real pain for patients.
All right, so I think we kind of talked about this already. How often do you check IgG levels?
I would say it's like a Bayesian adapted thing. If they're living up at 1,200, we don't check them again for 6 more months. But yeah, everyone that's close and everyone we're worried about with infections, yeah, we could check them monthly. And if they were 500 last time, we're definitely checking them monthly. And yet, I still do not know when to begin IVIG, as you were saying. I think the old New England Journal of Medicine article from 20 years ago is, CLL, and they were going at 100, they were repleting. Yep. 100 plus more than one infection. So that seems draconian. We don't wait that long, but we don't have the modern version of that study to say 400 plus one infection is the right trigger. That study really should get done now.
And I suspect you, much like me, have a bunch of these patients walking around with IgG levels of 250, which makes you nervous. But whenever you're like, do you getting infections more easily than anybody else? And they go, nope. And you go, all right, I guess I'm not going to drag you in here to give you IVIG then.
I offer them anyway, and they say no pretty much. And I can't fight with them because they haven't had an infection. Yeah. But it does make me a little. Yeah. Yep. It is weird how some people with the same numbers don't do as well as other people. Same numbers, yep.
And I'd love to say there's some pattern to it in terms of disease, but I don't think it matters. There's just some people, as we say, tolerate anemia well. Apparently some people tolerate hypogammaglobulinemia really well.
Yep.
So I think one thing we just really need to keep in mind is the number of side effects that patients have had from all of the therapies that they've been through. Oftentimes they're dealing with the cumulative effect of these therapies. So their quality of life can be quite impacted by all of these things and what they're dealing with. This is a relapse refractory twice group, and you could see, 97% of the patients said they had some kind of side effects they were dealing with. When we actually ask them, I should say in the green lines are the things that were most commonly reported. Hair loss, definitely, but fatigue. Fatigue is one of those things that our patients say has a big impact on their quality of life, but actually is often something that if they report it to their doctor, they feel like it's minimized. Or the doctor doesn't really understand what that impact can be. And so, I just like to remind you, there are clinical practice guidelines for fatigue. Just employ those. Also, help your patients understand what you're doing just to check if there are other things that are causing the fatigue. But if nothing else, help them with some practical tools to manage their quality of life through the fatigue. There are a number of tools out there looking at balancing time during the day when they're most feeling their best, as well as things like adding exercise, et cetera, into their daily life. But really then, when we ask, even if some of these things are not as frequently reported, we're also asking about what's impacting your quality of life the most. And you can see infections rates really high. The hair loss is interesting. Patients don't like losing their hair. Really, it's more, of course, of that visual representation. Now, if I haven't chosen to tell people that I have cancer, now they know because my hair disappeared really quickly. But again, their hair will grow back. The infection piece is often long-term and is impacting the kinds of choices they make about how they're going to live their life. And from that sort of impact, it's quite significant. We did ask patients in hindsight, would they change the therapy that they had or wish that they could? And you can see 1 in 5 said that they wished they had chosen or had been given something else because of the impact of the side effect profile. We also, though, went in specifically to those who were talking about the impact of the frequent infections and what that means. We already said that 60% of those who had frequent infections were reporting a severe or very severe impact on quality of life. But what's interesting is the 44% saying they were concerned about it. This was more the psychosocial impact of having frequent infections. So you worry about the fact that you might get an infection, or you're anxious about the fact that you might get an infection more than the practical aspect of I have one, how do I cope? And so really it's thinking about this in these 2 different ways because they have a different kind of impact on quality of life, but both of them are quite severe. And so patients do talk about how it increases their worry, it increases their fear, it limits their ability to socialize and hang out with the people that they would like to see, as well for those, and this is purely for those that were working or going back to work after treatment. A third of patients are saying that there is no accommodation for their immunocompromised status when they try to go back to work, and that again increases their fear and their worry. And it's like, how are we helping patients manage through all of these situations? And they often get mixed. When then we ask, how much was your doctor able to help or your healthcare team able to help with your infections? I like to point out, 15% here said that they never told their doctor that they were getting infections or that they were worried about that immunocompromised status. Of course, you can't help them if they don't tell you about it. I know you're probably asking your patients. I have news for you. Sometimes your patients are not completely honest. And it's not that they're intentionally trying to mislead you. Usually there is a reason why they're choosing to withhold some information. Some patients are fearful if they're completely honest about the side effects that they're feeling, that you're going to take them off the treatment, and then they don't know what treatment would be next or how you would manage their disease from this point forward. Others think that they can handle it by themselves. So they're just like, okay, I'm just going to continue to mask, or I'm going to do whatever it might be, avoid certain situations, and I'll be okay, so you don't have to worry about it. But even for those that do tell their doctors, you can see 28% say their healthcare team wasn't able to help, or they don't feel like their help they're receiving is enough. And so again, it's important to have those conversations to ensure that what you're doing to support a patient through this experience is actually something that they're finding beneficial. If there's something lacking, if there's something else that can be done to help them, and really kind of understanding why that might be, right? Somebody really wants to spend time with their grandkids, but their grandkids are germy, and so they don't feel like they can. Like really, sometimes it's like a counseling session more than it is prescribing something different.
I've seen some of those grandkids. They are pretty germy.
They can be quite germy, yeah.
I have a couple of those grandkids, and they are very germy.
Yeah.
Wow, you're so young. Oh, sorry, you mean, okay, I miss, yeah. Okay, we're going to talk about some future directions and more recent data updates, and I'm actually going to start it just by going to another audience question. This question is from, and I really enjoy saying these email addresses out loud because they're super funny to me, sgoob1021@aol.com. First of all,
AOL.
Great job sticking with AOL. I mean, there've been some ups and downs, but they provided good service, and I don't know if you're modeming in from your home modem line, but that's super cool. I think in Brooklyn, people are doing like cool retro AOL for their T-shirts and their man buns. Okay, so the question from sgoob1021@aol.com is, when will we see data? Actually, I don't really know sgoob, but I feel like sgoob is very dramatic, so I'm going to try to do sgoob's voice. When will we see data from the first line and second line EPCOR DLBCL trials? Whoa, sgoob1021, don't yell. And also I want to thank that guy. The questions about the first line, second line, EPCOR, DLBCL trials, I'm just going to emphasize the first line trials because that's going to be the most practice-changing thing, and the second line may go by the wayside once we have a first line result. So it is public data that both epcoritamab and glofitamab have frontline randomized trials, R-CHOP plus or minus EPCOR, Polar-CHP plus or minus glofitamab, and it is public data. You can clinicaltrials.gov it that they both completed accrual more than a year ago, something around there. So my quick answer, I don't know the secret backroom answer, but the answer is within a year from now. Yeah. That's my answer. You know, if you're sitting with your stock purchasing app and you want, I don't know the day, I'm sorry, yeah. But it's within a year, and both trials will be positive, so I don't know if that affects your planning at all. And so that's a good segue to the future directions and some updates from data. So we're talking about bispecifics for DLBCL. Everything we've been talking about is about CD20 bispecifics because that's where we have all these great approvals and mature-ish results. But we've got new things coming down the pike that are super cool. So one of them, and I've really been working on pronouncing this one because I usually just call this AZD0486. Now we're calling it Suravatamig. Why doesn't it end with an ab? Because it's got a funny structure. So it's like an ab, but it's not actually technically a mab. Part of it is just a heavy chain and no light chain, but they really make you struggle to pronounce Suravatamig. Suravatamig is in a few different trials. So, sorry, this is a CD19 by CD3 bispecific antibody with, I'm going to say, super cool results, some of which we're going to be seeing here at ASH. Great data in follicular lymphoma and good to great data in DLBCL, just not as mature yet, so we still need more patients and a little more follow-up. So the CD19 by CD3 bispecific, in some ways maybe nearly or comparably or almost as promising as the CD20 bispecifics, so that is super cool. And then this other one I only know a little bit about, GB261, which is in an early phase trial and has shown pretty high response rates in DLBCL. You can see 3/4 of patients getting responses. Excuse me, I take it back, sorry. 3/4 of patients on that trial were DLBCL patients. Yeah. I actually don't know the efficacy data yet, but we're going to be seeing some more data from GB261. And what we maybe don't appreciate enough is that in the background we have really a whole health support system that is allowing these patients to get these therapies. Lauren, let me let you talk about it.
Yeah. Just really quick, when we were, one of the things that we actually see is as patients go through diffuse large B-cell treatment, the number of barriers that they're actually experiencing goes down. You may think it would go up, you know, it's more complicated to get one of these future therapies. Actually, for patients, they find more support as they advance through their care. But still, even in the relapsed refractory twice setting, you have almost half of patients experiencing some kind of barrier to getting their treatment. The percentages for each of these categories are like all over the map. There's not one thing that sticks out. But just, you know, having those conversations again with your patients, if there's something limiting their ability to actually access their care itself, it's good to have those conversations and see if resources are available. Don't forget to look outside of your hospital or clinic. There's lots of community resources or resources from patient organizations that can be quite supportive and helpful some of these gaps for these patients. As well, just really quickly with the barriers overall, in our work where we've done the comparisons between patients that went to CAR-T versus those that went to a bispec, even though the percentages of the barriers themselves are similar, like the amount of people that are saying they had barriers, the severity of the barriers has been much less with the bispecs. So when their patients are navigating through, there are things that are simpler for them to fix, or they're not lasting as long as they are in the CAR-T space. So again, something to keep in mind if patients are indicating that some of these things are problematic for them.
So using bispecifics currently in the later lines of therapy, but as you heard, maybe in the future in early lines of therapy, is a multi-step process, and we've been lucky to have made so much progress over the last 4 and 5 years. You know, a big part of it is that because of the efficacy, we're getting some community adoption, but we still have some obstacles to community adoption. So still a big part of this is communication between community docs and academic docs. Not all the community docs. I think in follicular, it's been a little easier, the uptake, because no hospitalizations recommended or required by the labels. But in DLBCL, still an important role for collaboration between community docs and academic docs who are using these more frequently, because again, hospitalization can be a huge barrier for community docs. And there's parts about J-codes and billing that I know nothing about, but it's a very difficult process and sometimes an insurmountable barrier. Still, we can surmount it by collaboration. We have many models, some of which are the community doc hands a patient to the academic doc for the first cycle, and then we hand them back to the community thereafter, and a few other models as well. The nice thing is that now we're getting some long-term remission data and seeing some patients, even with these aggressive, multiply relapsed DLBCLs, where we're having durable remissions now even years later, not for all patients, not even for the majority, but for a significant proportion. So it is very cool that compared to other T-cell therapies like CAR-T, as you heard from Lorna, which have a lot of both logistical as well as quality of life ramifications, nice to have access to this off-the-shelf T-cell therapy. Okay, we're going to pause here. If folks have other questions, we would be delighted to do our very best to address them. You can ask them using the app. I guess if you scream it out, we're not going to listen to you. No, I'm only kidding. We'll have no choice but to listen to you if you scream it out. But we want you to do the app because we want to have these for posterity. And we're also taking these from the millions of millions following at home.
Millions of online audience
Tens of millions?
Right.
It was a high number. And also to get CME credit, you have to scan that thing. Again, I can get my 12-year-old nephew in here quickly if none of you have yet figured out how to use the phones. But I think you all look, it's actually a fairly young crowd. Okay, you probably know pretty well. And what I'm going to do here actually is my favorite segment of the show. It's something I like to call 4 awkward seconds of silence. What it does is it really lubricates the emotional space for people to ask questions, because people said, oh, I know questions, but when you really push them, sometimes they had one. You know, sometimes 15% of people don't even ask the question, so you do need to give them real opportunity to do so. So it's, it feels awkward, right? Yeah, I feel it here. I have to say, it really was not easy for me when you were talking, Lauren, about how quickly doctors interrupt patients. I wanted to jump in and say, no, we don't. No, we don't interrupt people. But I held it back. There was a struggle. And now I'll see if I can remember that struggle in clinic on Monday. Hopefully I can. Okay, I don't think we had other questions from the sorry, no, we do have one here. So this is a question from Evan Manjone, I hope I'm saying it close to right, at gmail.com. Very hip new email provider, yep. Gmail. It's one of the hot new ones I've been hearing about. Do you think STARGLO will stay in the NCCN guidelines? I'm going to give my answer, or do you want to take it first? Or
my gut answer when you asked that question was, I hope so.
That is an honest answer, and I, of course, feel the same way. And I'm just going to jump beyond my knowledge base and say, I can predict the future. Definitely yes, unquestionably. We should not be removing overall survival benefits from the NCCN guidelines, regardless if X% of the patients in the trial were Australian versus Chinese versus Western European, Eastern European. They are humans, their lymphoma is similar. The standards of care in these countries are a little bit different, and it would be good for us to include, for American FDA approvals, a certain number of American patients in the trial, because it's the most comparable thing to our patients. Regardless, overall survival prolongation is the gold standard of what we are all trying to do, so absolutely STARGLO. I'm going to say will stay in the NCCN guidelines. I no longer go down to Hollywood, Florida in February and be part of that, but we know those docs that do that. Yeah. They're all reasonable
Seems highly likely that that will continue to be the case.
Yeah, they want what we want, which is our patients living longer and living longer in some contexts with less toxicity than with some of the alternative therapies we give them. Okay, good. Did we do the 4 awkward? Oh, yeah, we did it already.
Did.
Great. Everybody, we want to thank you so much for participating. If you want to get credit, this is your very, very last chance. I mean, that's for official CME credit. If you just want us to acknowledge you at a more human level, we'll give you that credit too. You don't need to scan anything for that. But for the official CME credit, you have to scan it in. Okay, I think you had a chance. And everybody, thank you so much.